Hello, everyone, and welcome. We're just giving a few minutes for everyone to get logged on, and we'll get started. Just share where you're joining us from, and comments where all of our guests are dialing in from, and we're going to take some time. Hello again. My name is Marie Boone-Clark, and we're so glad you guys joined us this afternoon. I am very excited to work with my co-conspirator on this very important topic. I'm waiting to see if Dr. Yamicia has logged in. I thought I saw her come in, and then
I'm here. We're just having a little technical difficulties with the camera, but I'm here.
she's here. I thought I saw your name. Well. So we are offering a CE for this workshop for those who are nurses, and we'll give the QR code in just a moment. Our focus is on substance use during pregnancy. It's often a topic that's met with silence or worse, shame, but we're approaching it differently. We're approaching it with honesty, with care, with compassion, and with the skill and expertise of a brilliant obstetrician. It's my pleasure to introduce Dr. Yamicia Connor. We had her bio on the screen. We had her bio in the registration materials, but I also know that bios don't always paint the picture of the human behind it. And so I would like to invite Dr. Yamicia Yamicia to share a bit more about what she does, why this is a passion for her in terms of supporting mamas overall, and then talk a little bit about what I think is, I know this is a CE program, so I won't do an ad, but she has a wonderful organization that you have to go to her website and see. So with that and no further ado, I'll turn it over to you, Dr. Yamicia.
Hi, everyone. I apologize for the technical difficulties. I'm going to be shifting to my computer in a second, but it's an honor to be here. I'm very excited about this topic. I mean, about this entire week, really focusing around a population that often gets overlooked. And so I hope you all have a lot of questions. We're really excited to kind of dig into the topic and understand how we all can support these women better. So I'm going to try this one more time. Oh, let's see. I think it might work.
Recording in progress.
There we go. All right. There's only one of me now instead of two. So do you want me to project the slides and share them? Can you hear me?
Yes, that's perfectly fine. That way you're in full control.
Perfect.
And while she's doing that, I'll thank you, Aisha, for dropping it in the chat, because I was about to go on my spiel about how much I love the company, and then it was like, oh wait, this is a CE. And we've got folks, Doctor, joining us from New York, Chicago. I'm actually in Chicago, CJ Pruitt for the NMA today. Bakersfield, California, Detroit, New Jersey by way of Queens. So we've got a full house.
Excellent. So today our topic is going to be on Black maternal substance use in the U.S. We're going to talk about disparities, challenges, and paths to healing. So we're going to cover four main areas. The first is understanding the problem. So really trying to wrap our minds around the intersection of race, substance use, and maternal health. In many ways, I think about substance use in pregnancy as the almost like the equivalent of the criminal justice system for men, for Black men. Through pregnancy and motherhood, the state often you'll see is able to exert a very disproportionate effect on Black women that have implications not on them, but on their entire family and the society at large. We'll talk about structural disparities. We'll then review the legal and policy landscape. And then finally, we'll talk about healing-centered approaches that are trauma-informed and community-based. We have some reflection questions here, kind of embedded. I'll invite a few people, hopefully we'll have time. I'll invite a few people to kind of share their experiences, because again, this is not just me speaking to you. It really is. And one of the things we try to embody is the ethos of co-collaboration. And so we want to hear from you as well. Here are some learning objectives, like any good CE. We start with these. So by the end of this lecture, you'll be able to articulate the unique disparities and challenges that Black women face. We want you to be able to recognize systemic inequities in drug screening, reporting, and child welfare. We want you to be able to analyze the impact of current legal policy frameworks. This is critical, especially as the law and medicine is in the reproductive health space they're becoming fused in a really disturbing way that ultimately I don't think it's going to benefit the care of any pregnant women, least of all Black women. We're going to explain the principles of trauma-informed and healing-centered care for maternal substance use. Excuse me. And lastly, we'll provide evidence-based, community-focused strategies to support Black mothers in their recovery journeys. So we'll start by giving just a few moments to answer a question in your head, or you can kind of type in the chat. Which of the following trends best describe substance use during pregnancy in the United States over the past decade? Is it A, rates of maternal substance use have remained stable? B, maternal opioid use disorder has declined? C, maternal opioid use disorder and neonatal abstinence syndrome have significantly increased? Or D, substance use during pregnancy is now rare due to improved public health messaging? So that's one. And then our second one is, which factor is most consistently associated with underreporting of substance use by pregnant individuals? Is it a high socioeconomic status, access to private health care, fear of criminalization or loss of child custody, or D, a lack of knowledge about substance risks? And so I'll give everyone a moment. And these are not trick questions. The answer is very obvious, but I think it's important to really highlight how sometimes what is the most obvious, happens to be the thing that we as a community, focus on the least, or are the most are the things that are most often overlooked. Okay, so no surprise, the answer for the first question is C, that maternal opioid use disorder and neonatal abstinence syndrome have significantly increased. That's why we're here today. And then for question two, also C, a fear of criminalization or loss of child custody is often what drives women to not seek help. We have this framing in the US that if we want to incentivize good behavior, the way you do that is through punishment. And that's how our criminal justice system is organized. And even so many things in medicine are organized, with this adversarial relationship with the system, that if we want people to, do the right thing, the way of accomplishing that is by punishing them. And nothing could be further from the truth. The data doesn't bear that out. You probably in your own life probably realize, as soon as someone is yelling at you, criticizing you, does that make you want to just become a better person and change your behavior? Or does that more likely shut you down, and make you resistant to maybe reaching out to that person again, without actually encouraging some of the hard work that's required for change? So to just start with some framing, substance use during pregnancy is a complex public health issue that's become um, even more present in our, daily conversations as the rise of opioid use disorders has increased. And now that is intersecting with restrictions on reproductive health, making this a really salient issue. I think the other thing that I think it's important to point out too, is that it's now disproportionately affecting white populations and has therefore gained a lot of salience in our society, because people are seeing themselves in this disease, as opposed to just thinking about it as the other. Um, so for Black mothers, these challenges are compounded by structural racism in healthcare, social services, and legal systems. And in this presentation, we'll talk about each of these. Again, there's so much depth to this concept that we could have a whole, this could be a semester-long class. So we're just gonna, briefly touch on all the key points. And the goal is that this is just a introduction. This is just a start to understanding this issue, and that hopefully will inspire you to learn more about how you can help support someone in your community that might be struggling with substance use disorder. So just to look at some data in terms of the alarming trends that are happening. So light brown. The lighter brown line is showing maternal opioid use disorder at delivery and neonatal abstinence syndrome. And then showing the increase in the same, excuse me, this one is the maternal opioid use at delivery is the top one, and then neonatal abstinence syndrome is the bottom one, excuse me. And you can see very clearly that there is an upward trend in both of these. Oops. And so just to look a little bit at the numbers, by 2019, almost 6.6% of pregnant women reported opioid use, with another 21% acknowledging misuse. So this is not a rare issue. There are many women that if you take care of women in pregnancy, you are very likely, taking care of women, even if you might not be aware of, who have opioid use disorders. There are also, unsurprisingly, lots of racial disparities that persist in this area, particularly for medication-assisted treatment. So Black and Hispanic pregnant women are less likely to receive these services. And among Medicaid recipients, Black women, even though they do have access to health insurance, they are much lower, have a much lower rate of being offered this. So this is not an inability to pay. These people do have access to insurance. We're comparing two Medicaid populations, and you can see very clearly there's a difference. I'm going to skip that just for time. So we're going to talk a little bit more about the structural disparities. So there are kind of few key things that lead Black women to receive such poor care in this area. So unsurprisingly, the first is stigma. There is a fear of judgment and social disapproval. It's only very recently that we have started seeing drug use disorder as a disease and not as a personal failing. This is compounded by discrimination in the healthcare system. So you see discrimination across the board in every area of medicine, and that has impacts on the quality of care that people receive in this area. Maternal substance use is no exception to that. And then the last is stereotyping. And so when you look at the data, what you will see is when you take two equivalent people or women, one Black and one white, with very similar histories, the way that the medical system and the way society at large sees that individual is very different. So one might be a mother who is struggling, who needs resources, who needs to be cared for, while the other is seen as a criminal. And that has led to some of the large disparities that we see. So Black women are more likely to be drug tested and reported by authorities. I think the numbers, I don't know if we have it in this presentation, but the number is, oh yes, perfect. I was actually shocked when and this is as someone who does this work and has seen this with my own eyes, about the disproportionate rate of reporting to child welfare. And so again, identical populations, this study was well controlled, looking at white versus Black women who tested positive. And Black women have a 10 times higher rate of reporting, which is incredible. If you really stop and think about that and the huge implications that that reporting to child welfare has on you, your family, your children. It's not a trivial thing. Once you get into the system, it is very hard to often, be able to get your children back and be able to not be under constant surveillance. And when you think about the things that put someone there, I'll give you just a quick anecdote. I had a patient, unrelated to substance use, but I had a patient I wanted to admit to the hospital. She had no one to care for her kids. if you don't have someone to take care of your kids, the state will give you 48 hours before those children are put into a foster care. But you can't be admitted to the hospital with children like that. All hospitals have that policy because someone has to be responsible for those children. And so she quite literally had to choose between, do I want to, you know, risk losing my children, because this was not going to be a short admission to the hospital. She was, I was very transparent. This would be at least a week or more, most likely. Or was she going to risk her life? And that's like a situation that no woman should have to be put in. To make a very long story short, I ended up, taking, um, you know, a, temporary custody of her children, and they stayed with my children for about a week and a half while she was in the hospital. And we were happy to do it. It's much preferable to having, a woman that is trying to heal, also at the same time now needing to fight the system to keep custody of her children. So in my mind, that's a huge win. But this is not something sustainable, right? Like obviously we can't expect everyone to be in the position to do that. And so when we think about these women who are being, targeted by CPS, it's so easy to put them in the bucket of bad mother. But I want you to realize that this woman, by getting her care, she could have been very well in that group of quote unquote bad mothers, just for simply wanting to receive medical care. So this repeats a lot of what I mentioned, just some quick numbers I think to have in your head. 1 in 9 Black children will be removed from their parents at age 18. That was shocking to me. As a mom, that's terrifying to think about, the fact that, to even imagine the fact that someone could remove my child from my home and I could have the possibility of having my parental rights terminated. That's the sort of trauma that, again, drives people to things like substance use, drives some of the, you know, unpredictable and irrational behavior that might look like bad parenting, when in reality, it's stress responses from repeated systemic trauma. And so we see this commonly in the hospital. I have practiced in a few different locations in this country, and there's no standardized drug screening protocol, and there's no standardized, um, way that these drug screens are administered. Ideally and ethically, if you're going to drug screen anyone, you should let them know that you're testing them. This is not an I got you kind of moment. You should be very transparent, letting the mother, in the context of maternal health, know that you're testing her for substances and why. Some places have universal screening. That means everyone who walks through the door gets screened. And in some ways, that's probably closer to, if you're going to screen, that's probably closer to the ideal, because it gives less likelihood that the individual person that's caring for them, that their personal biases is going to affect whether that mom gets screened or not. But there are many places that don't do this. They just, depending on suspicion of the provider, either the nurse or the doctor or someone caring for her while she's in the hospital, that might prompt a drug screen. And when you're leaving decisions up to things like, up someone's personal suspicion, that's just deeply, deeply problematic, in particular because of the very significant implications that this can have on somebody's entire life. So there's bias reporting. Once they are in the system, Black families tend to face intense scrutiny and monitoring. And then finally, Black children are removed at higher rates, with a large fraction of these children never being able to return back to their families. The foster system has a disproportionate amount of Black children. So this is not rare. There are several states around the country that have what we call mandatory reporting laws. And so in 37 states plus DC, if a clinician suspects prenatal drug use, they're required to report this to authorities. There are about 25 states that actually put this in the category of child abuse. And then another 5 states that allow for civil commitment for pregnant women. And on one hand, people in the audience might be thinking, well, that's good. Like we want there to be consequences for mothers who are using these substances, because it can have real and serious consequences on the child's life. And while that's true, it is very rare that these programs or these laws actually provide the infrastructure for moms to get better. And so you are providing the punishment without actually providing any of the solutions or the resources that would help a mom recover successfully from drug abuse. And so all you in reality are creating is a group of, traumatized mom and children, mothers without resources, and also children who suffer immensely in the foster care system. And I just don't understand how that could benefit anyone. And so these punitive measures obviously have impacts not just on moms, but on their families as well. I'm going to skip through this. This is just showing the disparities in treatment access between if you have a Black caregiver versus a white caregiver. And you would not be surprised that if you're white, you get more access to both counseling as well as medication treatment. So root causes of this disparity. So what do we mean by the system is systemically racist? Like, what does that actually mean? I'm just going to provide just a couple of examples. So Black women are more likely to seek prenatal care and deliver in publicly funded clinics and hospitals. And the reason that this is relevant is because these hospitals have very high involvement of law enforcement. I was sharing with people about how it's very common for law enforcement to be on the units, on labor and delivery units in some of these poor communities. It's not rare. We deal with this frequently. And because these women are having so many touch points with the legal system, what the data has shown is the more people look, the more they're going to find. There's also legacy stereotyping. So the phenomena of the crack baby in the 1980s. And you won't be surprised to know now that the opioid epidemic is really ravaging a lot of white families. There's not an equivalent media panic happening. But you can imagine there could be, right? There could be a panic around neonatal abstinence syndrome. This is a syndrome that happens to the babies who are born to these women. But that doesn't exist. And you have to ask yourself why. It's not that these babies are not having real issues. It's not like they're not being exposed to dangerous substances. We are making a choice to characterize it differently. There are inconsistent protocols, and so that gives, again, more provider to provider variability. And then socioeconomic factors. So much of disparities come back to money because, we all know in this world, if you have resources, that buys you protection. That buys you the ability to shape the system to your will as opposed to the other way around. And Black women, for, many historical reasons that we're not going to get into today, are more likely to have to endure poverty. And that leads to inadequate prenatal care. And then the systemic inequalities just add on, add on, add on from there. So I'm going to pause for a minute and see if we have any questions or areas that people would like to explore further.
There's a lot of wonderful comments in the chat, more in terms of lived experience. There's someone who says, I'm a doula and I see it firsthand, no support, perinatal, just DCYF on speed dial upon delivery, social workers, no help. Someone else said exactly these numbers are rising as well, and why I also became a doula and now foster parent with preference of Black, brown children. Black, brown women are assumed to be under the influence, even if tired from being up till the wee hours with family, as was the case with my second eldest. Um, a lot around the system being punitive, Dr.
Yeah.
Y, and a lot of people um, uh, confirming or are agreeing with your assessment. One of the things that you said that resonated to me was about the 25 states that mandate. Is that correct?
Mhm.
So my question would be is if I'm a practitioner and I'm trying to be compassionate, if the
Right.
state says that, say, for example, that I must report, if I do not, as the nurse midwife, maybe, right? Or the OB, and then mom is admitted for her delivery, am I somehow held accountable when the hospital tests her and they find that she's positive? Will they
Right.
yeah, is that
Yeah. No, it's a very good question. And yes, you probably, we don't encourage anyone to break the law. And so, but there are ways of handling this situation. So I very commonly tell patients that I'm a physician. You know, I have certain things that if I learn about, I by law have to report this. And so before you tell me anything, I want you to know that so that there is no, again, it is really about giving the patient all the information that you yourself have. Because if they make the decision, and some people do, right? Because they're like, I need help and I'm willing to face the consequences because if I don't, then I don't ever think I'll get the help that I need. Fine. They made that choice. It was a choice that was informed. What is not ethical, and I think clinicians should not do, is lie, right? You shouldn't lie. And if you are collecting labs and tests without telling the patient what it's for, that's a lie of omission. And that there to me, there's no excuse for that.
Mhm,
You
mhm.
can always be honest with people, and because they know your role. And what I have found is most patients are very reasonable. They understand that you have a job, you have a boss, you need to follow law. These are women who live in the world and all of the expectations that the world has of you. So they understand this, but you can still follow the law without being unethical, in my view. It just requires an understanding and a compassion of like, what would you want if this was your daughter? And I
Right.
hate that framing because it shouldn't be required to be your daughter for you to be compassionate. Like that shouldn't be the requirement. But today often it is. If people aren't able to see themselves in this scenario, then it's very easy to other somebody. And the last thing I'll say about this is in society, we like to have like a good, bad
Mhm.
paradigm. Like this person is good, this person is bad. When in reality, we know people hold multitudes, right? People are both good and bad. They make good decisions, bad decisions. We all do. But the way that systemic bias comes in is when a Black person makes a bad decision, they get punished for it. And I can say, even just from my own experience, I've always been a really hard worker. I've always put in 120%. And I can name very, specifically the few times that I wasn't able to do that very clearly. I have very distinct memories of what happened because I faced consequences. So no matter you can spend 99.9% of your life being as close to perfect as possible, but that one time, the system does not forgive you. And that's what we're talking about when we say systemic bias. It's that because nobody can live under those sorts of requirements. Of course, you're going to find disproportionate amount of rates of Black women who are involved in, you know, less than ideal activities. Of course, right? Because every single one of them, you are going to work very hard to punish. And that is really where I caught. That's what I really ask people who don't understand this to think about. Like if every mistake that you made resulted in a very tangible consequence that you have to live with, that's an enormous amount of stress. And the reason I can say this is I have felt that stress. I have felt the stress of knowing that you are not going to be forgiven. And that's why so many Black women are out of the corporate workspace, right? The Black women are have the highest rate of entrepreneurship. It's, this is not related directly to this conversation, but it demonstrates the bigger question, the bigger problem. And that's because they can't find an effective way to still be human and succeed in the system as it's been denied. And that same concept, it's true whether you are a physician like me or you're a poor mother struggling with substance abuse. The system does not provide you opportunities for weakness and ability to bounce back. The other, I think, important thing to mention is that substance use is actually pretty common. Um, you'll be surprised the people who use substances, they're not all bad parents. And so you really have to understand the context. When I practiced in Boston, there were so many white, high socioeconomic status women professionals that we would discover that they have an opioid use disorder because we could see the effect in the babies.
Mhm.
And no one ever thought about drug testing them. It never even crossed somebody's mind until we saw that the baby was like obviously withdrawing from some substance that they were exposed to in utero. But that doesn't happen for Black women. It's often the other way around. Even if there's a suspicion and the tests are negative, oftentimes the system is not satisfied with that. They want to try to find more. They want to say she must be hiding something, or maybe she hasn't done the substance use recently, because it has to be the case that this person who fits every stereotype of what I see as a poor mother, that she must be doing something wrong. I just haven't found it. And I have experienced that huge dichotomy, and it's very disorienting um, when you practice in systems like that. It's even to the detriment sometimes of for white patients, because there have been people who are so clearly under the influence of some drug, suffering from really serious consequences, that aren't getting drug tested. It's like we're looking for literally every medical mystery to explain why this patient is having this, let's say they're in the ICU and they are, they have like very high hypertension that we can't control. It is easier for the system to convince itself it is some like rare pathology, like it's a like a pheochromocytoma, and not that this woman has like a cocaine use disorder, right? If you rather it be that this very rare tumor than the thing that's right in front of your face. And I have like seen that myself and literally have been dismayed by the willful blindness people have, because they quote unquote like they like that person, right? And that's
Mhm.
why I think that framing is really dangerous in medicine, when you describe a patient as like, oh, that's my favorite patient, or I really like them, or they're really sweet. That on one hand, it's like you are, trying to, connect on a deeper level with that person. But on the other hand, that means there must be patients that you don't think are sweet. And how do you treat them? And so you will rarely hear me classify a patient as like, oh, she's so sweet, or she's so XYZ. Because on the flip side, there's that patient that you don't have that immediate rapport with. And it's those situations, if you're not careful, that lead physicians to continue to perpetuate these stereotypes. We're
Quick
gonna
question, Dr. Right before we move, the slide, I had said, if I recall, you said there are 25 states, correct? That require mandatory. The question is, which 5 states have mandatory commitment treatment for mothers using substances? Which 5 states? Oh, there we go.
Yeah,
5 states allow civil commitment, forced treatment of pregnant women for substance use. Do you have the list of what those 5 are?
we do. I don't have it off the top of my head, but I'm sure it's in our notes. So Aisha, if you're here, if you can like pop it into the chat. Um, yeah, I don't have it readily available. I apologize.
Thank you. That was one of the questions that just came in. And then we'll,
Go ahead.
no, I just said I was putting that in, but we'll
Okay.
for you.
Okay. So next we'll talk briefly about legal and policy landscape, because we're not, again, there's so much material here. So we've talked a lot about what criminalization is. Let's talk about what a public health approach would look like and how that's different. It would treat substances as a health condition, which from the medical standpoint, substance use disorder is the same thing, it's no different than if you had heart disease, if you had cancer. It's probably a better equivalent to think about is obesity, because there are some people who view obesity also in that same vein of um, a person has made a moral decision to have this condition. But we know, and what the science has shown us, is that this is a health condition, and there's really good reasons to think about why. We know that some people are more prone to substance use. There are some people who can use drugs and they don't get addicted. They can use it on the weekend and then they go and have a very normal life and they just use it socially and recreationally. And you never hear about them, right? Because they're able to live a completely normal life. And this is not that rare. That's what I also wanted to point out to people. It is not that rare. I'm sure you know people in your life who use drugs in this way. But then there are another fraction of people who, after using a substance one time, it activates something in pathways in the brain that we don't really fully understand, but we know that their behavior is inherently different than that other person I described. So that's why it's a disease. This is not some liberal formulation to try to help people avoid accountability. This is backed in the science. And the reason I say that now, I probably, 5 years ago, I wouldn't have made that statement, but I think it's really important today more than ever to make it very clear why we have certain stances on issues. Because it's not just personal beliefs or willingness to not, you know, a desire to not have people be held accountable. It's because the data is showing us that there is a biological reason that makes this person different than someone else. And that's not to say that behavior does not play a role. We know that if you smoke, you're going to have a higher risk of heart disease. But you don't tell the person who just had a heart attack, well, I mean, I guess you deserved it because you're a smoker, right? We don't have that framing. And I really encourage people who are struggling with this concept to try to create analogies that help you really understand, why is this a health condition? Because if you can wrap your mind around that paradigm, then all of the treatment approaches start to make a lot more sense. Um, so unfortunately, we're heading in the absolute opposite direction of being more public health focused. We are heading into wanting to punish women for these, you know, for I would say anything. I mean, a bad decision that the state is not that the state does not look favorably upon is now becoming a reason for women in pregnancy to be criminalized. And so we have several states that have fetal assault laws or fetal homicide laws that treats a fetus as a crime victim. And all of these laws were designed to punish the abusers of women. In reality, what they're being contorted to do is to punish the women themselves. And then we also have, 29 states that they apply these laws from conception through birth. And so even when, you know, in theory, when you don't even know you're pregnant yet, you still could be committing a crime that's punishable. So imagine all the people who are, drinking glasses of wine, and they don't yet know that they're pregnant. They could be committing a crime. And that's why these laws are incredibly dangerous. I'm going to skip over some of these just to, just to give some time for discussion. I'm going to, point out some of the high, the high salient points. So we know that this does not benefit babies. This, punitive system does not help. It does not achieve the goal in which what we set out to do is not achieved through this. What happens instead is that you have decreased prenatal care, so women just don't go to the doctor. There are worse birth outcomes. There's reduced honesty. And then we have missed treatment opportunities that do not benefit the person, but they also don't benefit society either. Because it's in everyone's best interest to help a mom take care of her children by supporting her and giving her the resources that she needs to, right? We're talking about ways of finding efficiencies in government. This is an efficiency. So even if you are not driven by the humanity of the issue, everyone should understand that the more we keep families together and they're able to successfully care for their children, that is a society that is maximizing its resources properly. But instead, what we have is a system that is really designing itself to just like a, positive feedback loop where someone makes a mistake, they get punished, all the resources get taken away from them, and so they're going to make another mistake and another mistake, and then you have people who can never get out of this cycle, and society loses from that, and obviously the children and the mothers and the entire family loses. So this just highlights that medical organizations also advocate for this framing. So this is not something that is just kind of my opinion. This is the stance of our professional organizations. I want to talk, we'll end a little bit on trauma-informed care, because I think it's really important, given the number of women and girls who are exposed to very traumatic experiences throughout life that then manifest as something like a substance use disorder. Just to give you one stat, we're talking a lot about in kind of the general society about on sexual abuse of minors. But what I have not heard anyone talk about is how common it is. 1 in 4 women have been sexually abused by the time they're 18. That's 25%. That's a core of the people probably sitting in this room listening to this lecture today have this trauma in their history. And so when we're thinking about why are women making these decisions, we have to remember we live in a world where there are very few resources given to people. And now we're taking away a lot of those resources. The very few we gave, we're now taking away. And we know that humans cannot thrive in an environment where they feel ostracized, where they feel like the other. That's just not how we are built as human beings. And how you see that manifest in society is it are things like substance use disorder. Like that is the root cause. Because in lieu of actual treatment, you're going to find some way to cope. And one really very common way is by using drugs, because they, for at least a moment, allow you to escape things that have happened in your past that you haven't been able to fully understand, contextualize, and work through. And so I think it's really important when we're thinking about these women, and if you care for these women, to also go the next step and ask the question of why. Why do you think she's making these decisions? Because too often we just decide like, well, it's obvious why. They're bad people. And that couldn't be further from the case. So we'll provide some of these slides for the group. There was one last thing that I wanted to touch on, and then we'll just open it up for questions. Let's see. Okay, so there are a few harm reduction strategies that I think it's important for those of us who care for these women to be aware of and have kind of in our arsenal of how we take care of these patients. So the first thing that's not on here, but you have to help people in their honesty. And so what does that mean? You have to make it very clear to patients in direct ways and indirect ways that you are there to take care of them and try to help them achieve the best outcome for themselves and their unborn baby. That you are not part of a legal system, that you are not trying to get them in trouble. And the way that you do that is you create an environment that demonstrates to people that you understand that this is a problem that they may be confronting. And so it shouldn't be uncommon for you to be asking a patient, have you used any substances recently? The same way you would ask them if they've had headaches or if their nausea is getting better. Ask them this question. And you'll be surprised how many people are very honest. And it doesn't offend the people who aren't. They're just like, no, I haven't. But it provides that opening for those who are struggling to find a way to ask for help. It provides them that small little opening that they might need in order to be able to have an honest discussion with you. And that is so far from the way that we're trained as physicians. We do the exact opposite things that you should do if you really want someone to be honest with you. We ask them in very awkward ways. The counseling we give is often very it's often very like accusatory and makes it clear that we disapprove of the behavior. And when someone senses that from you, and it's very easy. I mean, we're all humans. We all understand body languages. We can read each other's energy. So a patient's going to very clearly see that like you are disappointed in them, or you no longer like them, or you no longer respect them. And what's going to be the consequence of that is they're not going to seek help from you. And what ultimately ends up happening is these moms don't get the treatment that they need, and the babies are still exposed to the substance, but also don't get the care that they need. Because it's not like these women don't get preeclampsia. It's not like they don't get, other diseases of pregnancy. If anything, they're at higher risk. And so because you've isolated a woman who uses, an illicit substance, you've now created two problems. You created a problem of, her feeling ostracized from the system. But the second thing is now you have someone who's very high risk, who hasn't had care in pregnancy, and you will see that person at some point, but it's going to be like at 30 weeks when they're in the emergency room with a massive abruption. And again, like if you're thinking about this just from a system perspective, and I'm speaking to like the physicians and the healthcare providers out there, nobody likes that. Nobody wins when that happens, right? We obviously don't win because that's one of the worst situations to be in as a clinician. Is you have a person who's very sick, who has no medical, who you know nothing about, and very quickly you need to create a plan of care and find out this information. And wouldn't it be much better if that person all along was seeing you, so that if and when a bad event happened, this is a patient you know very well, right? And that makes everyone's job easier. And so to kind of close on, I wish we had time to kind of go into depth with some of these topics. We're going to be putting more information out. But to speak very broadly, there are 4 harm reduction strategies that we recommend. So one is medication assisted treatment. That's something that Black populations do not get enough exposure to. We know that the medications work and that they're safe, and we need to do a better job of reducing stigma. There needs to be safety planning. So we need to acknowledge that not everyone's going to be able to stop their drug use. And so if you aren't able to stop, how do we keep you as safe as possible? We need to be family centered. And so helping, you want, it should be it is in everyone's best interest for that child to stay with their family. And if the mother's not able to to do that at the moment, the system would be better served by us trying to help her create strategies that could ultimately lead to reunification. So is there a grandmother that can step in, an aunt, an uncle, a mother-in-law? Are there other resources that we can lean on that provide a safety net for the child while also giving the mom a real opportunity to get better? What does not help is now you have a mother who, for you know a lot of reasons, trauma, untreated depression, she's now turning to substances to treat that. And then now you've given her the even bigger problem that she no longer has custody of her children. And I don't know how anyone expects someone to do something that's incredibly hard. If you've ever been addicted to something, breaking addiction is very hard. So you can't expect someone to do one of the hardest things possible, while at the same time putting them in one of the worst situations possible. That just is a recipe for failure. And the last thing is that I'll mention is doula support. So there are doulas that are specially trained in harm reduction and trauma-informed care. And that is another great tool that's underutilized by clinicians. When a patient looks at the hospital system, it's not just the care that you give as a physician or as a nurse, right? The experience is shaped by everyone from the minute they walk into that building to the minute that they leave. And we all know that, there are sometimes patients who've never met us who don't like us because they had a bad experience in the lobby, and that now has translated to us. And doula support is such an effective way of providing that trusting relationship, but doing it in the context that is practical for the system. Because I understand clinics have to run. Providers can't spend the maybe hour and a half that might be required in order to build trust with this patient. It's just never going to happen. But are there other methods? Are there other people? Are there other ways that we can use our team more effectively to build a trusting relationship with the patient? And you as a doctor are just one part of that team. And their experience is not just based on your care, but it's based on the entire relationship. And that's one thing we take really, that's really important to what we do in the communities that we're trying to create. And it's one tool strategy that for providers who are struggling with this, one way that you can also create a more welcoming environment without having to put unrealistic expectations on yourself or the team. And so I'm going to stop there and see what questions we have.
So much rich information and so many conversations in the chat, and again, agreement with you in terms of suggesting, seeing that whole patient and treating them as a human. I know we are short on time, but if you have a question and you want to stay over, I think I can speak for Dr. Y. We won't rush you off. I personally think this is such a critical discussion that we need to have. As someone who spent a lot of time in the hospital as the medical sales rep, seeing how these mamas were treated, and the fear that so many of them had to, in terms of being, truthful. was heartbreaking. And then I love the point that you made, Doctor, about the assumptions that people make. There was someone in the chat who shared her own testimony that said she herself had taken Percocet for 17 years for 2 back injuries from 3 patient assaults as a psych nurse. After 11 years, I was referred to a psychiatrist. I love him. 3 to 4 years after starting with him and multiple OTPT sessions, I was and still am off of Percocet. My PMH in P and and a specific doctor told me, you're not addicted, you are physically dependent on it. PT will get you off. And this person says, I have my MS in nursing and I'm a certified midwife. So the stereotype that people tend to have, right? I myself, speaking of being in a hospital, we were in a hospital in Kentucky where, as you know, there was such a high, or still is, use. And there were some comments by nurses as we were having the conversation with a neo that did some training for us. And one of the nurses, who just looked like an absolute Barbie doll, and was married to a physician herself, made a comment about she too had been addicted. And the way she put it was, do you think I got this body from nature? But it had come from all of her plastic surgeries and the surgeons giving her opioids to
Yeah.
deal with, the pain. So we shouldn't stereotype. And it's heartbreaking for me that the statistics that you shared about our children and how they are in the system. So lots of conversations, questions. I don't see any further. Oh, the one question is if you would be willing to share the slides. And then I'm going to ask permission. Is it okay for us, of course, to share the recording the way we normally would?
Yeah, absolutely.
Okay, we'll share the recording. And then we can work with Dr. Y to share the some of her slides. This was beautiful. I know there was a lot that you didn't get to. As you were scanning through, we might have to beg her to come back and do a part 2. One, I think that would be a really good time is during Black Breastfeeding Week, because we know there's a lot of discussion around what is appropriate for mama who is lactating. So I'll ping that now, Dr. Y, and we can see if we can't get on your schedule, if
Yeah.
not during that week, whenever it's convenient for you. To the rest of you, thank you for joining us. Join us in a few hours. We will continue our conversations at 7 Eastern. We have You're Not Alone, The Psychology of Infertility with Dr. Erica McKinney, who's going to talk about the trauma of going through fertility treatments and how we can best support those mamas. And then at 8 o'clock, we have a discussion around postpartum emotional health with Dr. Janet Williams, entitled Beyond the Bump, Protecting Your Emotional Health. And joining Dr. J, who many of you who've been on our workshops have know is a dear friend of ours. Joining her will be Rosalie Henry, who is a brilliant postpartum support doula out of Atlanta. So thank you. We will see you in a few hours. Thank you, Dr. Y, again, for always being such a support of our work. And we very much appreciate it.
Yeah, and if I can just mention, we have a series coming out just on maternal substance use that really goes into depth about all of the things we weren't able to cover. So we will make sure to share that with you.
If you get it to us, we'll get it to our village and we'll make sure everyone because the more you know, right?
Right, exactly. Thank you, everyone.
Thank you, ladies. Have a good
Bye.
day.